Hello, my name is Fananapazir, and I'm a professor of radiology at Mayo Clinic, Arizona. Real pleasure to be here at the SRU and to be talking about renal transplant Doppler. I have no relevant disclosures. So we're going to be looking at Doppler ultrasound of the kidney graft from a few different perspectives. One, we're just going to look at the normal anatomy of a kidney graft, what we should be looking for. Secondly, we're going to go over the major vascular complications of kidney grafts. Finally, looking at collections from the perspective of Doppler, and then finally, parenchymal abnormalities within the kidney graft as they relate, again, to Doppler imaging. So normally, a kidney graft is placed in an end-to-side anastomosis with the external iliac artery, as you can see here. But occasionally, the external iliac artery is diseased, and sometimes the surgeon will opt to go for an end-to-end anastomosis with the internal iliac artery. Now, there are also other kinds of kidney grafts that can be used. Sometimes they use two adult en-bloc kidneys, but another popular tool is pediatric en-bloc kidneys, where the kidney grafts themselves, the renal arteries, are too small to anastomose. So they end up taking the kidneys en bloc and use the donor aorta to anastomose to the iliac artery, and then the donor inferior vena cava to anastomose to the iliac vein. So it's important to know what the actual surgical specifics of the kidney graft are before actually doing our ultrasound evaluation. Now, the other thing to know is that there are is usually a main renal artery, or sometimes there are two renal arteries. Then they have segmental branches, which you can see here, the segmental branches going into the kidney graft. And then finally, between the medullary portions, you have the interlobar artery. Arcing around the medulla and separating the cortex from the medulla is the arcuate artery. And finally, you have these small little vessels that are perfusing the cortex, which is the functional portion of the kidney graft. And those are your interlobular arteries. So when you're looking at perfusion, looking at those interlobular arteries to see if there's adequate perfusion to the cortex is going to be important. Now, another thing to keep in mind when we're looking at kidney grafts is that a lot of these grafts, those that are coming from deceased donors, not living donors, but from deceased donors, a lot of them will come with a Carrel patch, which is a patch of the aorta, which they anastomose. So the proximal portion of the renal artery is not actually the anastomosis. This Carrel patch is actually your anastomosis. Perfusion, we have a number of different options. You can see we have color Doppler on the left, power Doppler in the middle, and then finally B-flow on the right. Now, B-flow is not a Doppler image. It actually uses grayscale images to generate perfusional evaluation of structures. But one of these three options is useful. But again, the importance is to make sure that not that there's just perfusion to the graft, but that the perfusion goes all the way out to the cortex. And then finally, if we have difficulty making sure that flow goes out to the cortex, we always have the ability to be able to perform contrast-enhanced ultrasound, as you can see here, where you can see prompt uptake of the contrast all the way out to the cortex. So we divide complications into a few different vascular complications into a few different ways. One, we can talk about what are the early complications of kidney grafts. The second thing we can look at is what are the later complications, those that occur 1 month to a year typically. And then finally, we can look at those that are iatrogenic, those that can happen at any point, either from the time of the surgery or some kind of intervention happens with them. Now, the early complications are going to be those things that deal with thrombosis. That's going to be your arterial and your venous thrombosis. When you're talking about later complications, we're really talking about stenosis. And then when we're looking at iatrogenic complications, we're dealing with pseudoaneurysms, arterial venous fistulas, and hematomas. So let's take a look, first of all, at arterial thrombosis. Arterial thrombosis can be due to an embolism, thrombosis, dissection, something that occludes up the arterial blood supply and typically occurs within the first few days after transplantation. And it's typically not a diagnostic dilemma. Here you can see complete thrombosis of the kidney graft where the artery is thrombosed, and then you see no perfusion whatsoever within the graft. Now, if the thrombosis involves a segmental artery, or if it involves, if the patient has more than one renal artery and involves one of those, you can actually see that you can get perfusional abnormalities involving one part of the kidney graft. In this case here, it's the inferior pole of that kidney graft is completely thrombosed. Now, contrast enhanced ultrasound is also an option. Here you can see a pediatric en-bloc kidney graft, and there's absolutely no uptake of contrast. You can see the contrast in the surrounding tissues. This is a case of arterial thrombosis. Now, because the arterial thrombosis was able to be recognized right away, they were able to do a thrombectomy. And here you can see there's perfusion now in the kidney grafts, the pediatric en-bloc kidney grafts, but you can see there's areas of infarcts, these wedge-shaped hypoechoic regions within the kidney graft itself that indicate infarcts. Now, venous thrombosis can be a little more tricky than arterial thrombosis. What you typically see is going to be a decreased perfusion within the kidney graft, manifested most profoundly in the cortex. You're going to see reversal of diastolic flow within the renal artery. And the thing that makes it difficult is that there's overlapping features with acute tubular injury. So really the way that we have to be able to evaluate this with and distinguish it from acute tubular injury is to look and make sure that there is a vein draining from the kidney graft. So there are some pitfalls though. This is a case here where the sonographer thought this may be a renal vein because it was coming away from the kidney. The kidney was located over here, and this was coming away, so it was thought to be a vein. But when you look at it on color Doppler, on a cine clip, you can see it's alternating between red and blue. When you put the spectral on it, you realize that the blue is just the reverse diastolic portion, and the red is the systolic portion. So in this case here, there was no renal vein. This is a renal artery with reverse flow. Now you can also see here there are some fluid collections with fluid levels. This is a hematoma that's developed. A lot of times patients who have venous thrombosis, they have high pressures, and these can lead to rupture of the kidney and the presence of hematomas. So that's something to look out for as well. Now, grayscale can sometimes show you the thrombus. It can be difficult, but in this case here, you can actually see connecting with the iliac vein, this structure here that contains thrombus. This is the renal vein thrombosis. Now, when we're talking about transplant renal artery stenosis, which we're now moving on to, it's important to understand some of the flow patterns. Now, there are three flow patterns that exist within arteries. The first of them is plug flow. Now, in plug flow, all of the blood vessels travel the exact same speed within the vessel itself. So here you can see these red blood cells, they're all traveling the same speed. How does that relate to what we see on spectral? Well, in spectral Doppler, you can see this narrowing of the spectral window. You can almost trace it with a pencil because everything is going the exact same speed at the exact same time. So you get this really thin spectral window. In laminar flow, you get high velocities in the central portion of the vessel and slower velocities in the periphery. And that's because they rub up against the wall of the artery itself. And so this leads to a little bit of spectral broadening, not complete spectral broadening. You still have a low clarity under here, but it's a little wider than the image before. If the one before we could do with a pencil, this one we probably have to draw with a Sharpie. And finally, turbulent waveform is when they can go any velocity they want, any direction they want. You get that turbulence that occurs. And this is shown as complete filling in of the spectral window. So how does that relate to transplant renal artery stenosis? Well, typically when you're looking at transplant renal artery stenosis, the renal artery itself, because it's not a large vessel, will have laminar flow. And then when you have a stenosis, it's going to move on to plug flow. And then finally, distal to the stenosis, you're going to get turbulent flow. So it's important to try and look at those waveform patterns. In addition, right at the stenosis itself, right at the narrowing, you're going to see very high velocities. And then finally, you're going to see parvus-tardus waveforms within the intraparenchymal arteries. So when we were looking at how do we figure out if transplant renal artery stenosis exists? We looked at a number of different factors, and 3 factors really came out as being important in evaluating for transplant renal artery stenosis. One of them was, is their velocity greater than 300 centimeters per second? The second is there that turbulent waveform pattern that you can see in the renal artery, which suggests a more distal stenosis, a stenosis that's more proximal to that area? And then finally, do you find parvus tardus waveforms within the intraparenchymal artery? And what we found was that it's not so much binary by ultrasound of is there a stenosis or is there not, but there are really a number of different categories you can have. If you have none of those 3 criteria, there's really a 0% chance of a stenosis occurring. If you have all 3 of those things, there's about a 100% chance of a stenosis. But the part where it becomes tricky is what happens if you have only 1 or 2 of these. And what we found is that the rate of finding stenosis increased with the number of factors, that if you only had 1 factor, it was about a 33% chance. So if you only had turbulence, or you only had parvus tardus, or you only had a velocity, there was about a 33% chance. If you had any 2 of those, then you ended up having a very high rate, a high rate of stenosis, somewhere around 90%. So here's an example here where you can see we're right at the proximal portion of the renal artery. Let me run this cine clip for you. You can see there's this soft tissue vibration that's going on with this bleeding of color flow. There's aliasing happening right here. So we ended up putting a spectral Doppler over there. Here you can see that plug waveform. You can almost draw this out with a pencil. This is high velocity plug waveform concerning for stenosis. And then here you can see this vibration artifact that's coming up on the spectral image. More distally in the renal artery, you have spectral broadening. You have that turbulent appearing waveform pattern. Then finally, when you go into the intraparenchymal arteries, you have delayed upstroke. So this is parvus tardus waveforms. So this ends up being a high risk, or a very high risk, of transplant renal artery stenosis. And sure enough, the patient did have transplant renal artery stenosis. Now, it's important when we're looking at transplant renal artery stenosis that we look beyond the anastomotic region itself. Most cases of transplant renal artery stenosis don't occur at the anastomosis. Most actually occur within the mid-renal artery, as you can see on this image on the right. And some of them can be quite complex. You can see a diffuse long segment area of stenosis with some beading within it. So, confining our view just to this anastomotic region or the proximal portion of the renal artery is probably, will probably lead to missing some cases of transplant renal artery stenosis. So a few other pearls, don't look at the velocity alone. Velocity is important. It's one of the major criteria, but it's possible to diagnose transplant renal artery stenosis with a normal velocity. And that's sometimes because it's difficult to see all portions of the transplant renal artery. They can be tortuous. It can be difficult to visualize. So relying on the other features can have added value. And then finally, when we're looking at cases of transplant renal artery stenosis, since we're not dealing with a binary of yes, there's a stenosis or no, there's not a stenosis, it's important to have the possibility to evaluate it with a different modality, perhaps CTA or MRA. We use MR with ferromoxidol to be able to evaluate these patients. So that's something to consider as well. Here's an example of a report that can be used when you're evaluating, since a lot of times nephrologists are actually looking for transplant renal artery stenosis. So this is a good potential way of looking at it, where you can give in the finding section, you're listing your concerns of 3 major factors. And then when you have the impression, you can give what your risk category is. Is it low, intermediate, high, or very high? And then these are some recommendations that we came up with along with the transplant nephrologist based off of the imaging findings. Moving on to arterial venous fistulas. Here's an example of me doing a biopsy. I take my needle, it hits an artery, it hits a vein, and now I've created a connection between the artery and vein that bypasses the higher resistance, more distal arterioles. So here the blood flow comes in, it becomes very fast right here, low resistance, and then goes into the vein. And some flow may go distally and some flow may go proximally. So here you can see on this particular image here, you can see the soft tissue vibration that's going on there. And then you can also see aliasing happening right here. And then you put the spectral window over it, you have high velocity, low resistance waveforms indicating an arterial venous fistula. And color Doppler is actually very sensitive for being able to detect small arterial venous fistulas, predominantly because of the soft tissue vibration. Here's an example here where this patient had 2 renal arteries, and one of them was involved in arterial venous fistula. You can see what it does to the resistive index. The one on the left drops the resistive index down to 0.47, whereas the renal artery on the right image here was at 0.88. So it can really decrease your resistive index within the affected portion of the kidney graft. And here's a nice example here of a biopsy that was probably a little too steep within the kidney graft. It caused an arterial venous fistula. And here you can actually see quite nicely the arterial venous fistula right here that is stealing blood away from this portion of the cortex. So you can see this cortical perfusion defect. So arterial venous fistulas can lead to some degree of ischemia within a kidney graft. Finally, as far as vascular complications, you can have pseudoaneurysms, which are contained vascular injuries. The vessel is injured, it's contained either by hematoma or surrounding soft tissue structures. Blood flow comes down through the hole, the rent in the artery, up, around, and since it's going towards the transducer, it's going to appear red. Away from the transducer, it's going to appear blue, and now it's going to come back down the vessel. So how does it look? On grayscale, it's just going to look like an anechoic structure, like a cyst. You need to put color Doppler on it to make sure it's not a cyst. Here you can see that kind of yin-yang appearance, and then you can see the swirling of the flow within the B flow images and the image on the right. Okay, finally, collections. We're not going to get, or not finally, but collections, we're going to just talk about hematomas. I'm not going to go into the other collections, and hematomas can occur either most typically right after surgery, but anytime you do an intervention, hematomas can develop. And so, I like to think of hematomas in 4 ways, and I think about them in terms of how worried I am about them, with incisional collections being the least worrisome, lateral collections the second most worrisome, subcapsular collections worrisome, and medial collections having profound possible implications on the graft and the patient. So let's look at incisional collection here. Here's a body. You can see the graft here with the arterial and venous anastomoses. And then here you can see this incisional collection. These usually don't amount to a whole lot. They typically resolve by themselves. Maybe they can become infected, but that's about the extent to which one needs to worry about an incisional collection. Now, lateral collections can have some kind of mass effect on the kidney graft. But they can also have a propensity to get infected. So a lot of times if these are large, they may be washed out by the surgery team to make sure that they don't become infected. And then sometimes they can have some mass effect on the kidney graft itself. Now, the ones that can really have a mass effect on the kidney graft are the subcapsular collections because they're contained within the capsule and they can indent the kidney itself. And the challenge with subcapsular hematomas is that they can actually have this similar echogenicity to the kidney parenchyma itself and can be tough to see by ultrasound. What you typically see on Doppler is going to be reversal of flow with this high resistance created by this pressure effect on the kidney graft itself. So it's important when we see that reversal of flow within a kidney graft, we really check and see if there's a subcapsular collection within there, either by ultrasound or potentially by CT with contrast, as you can see in the image on the right. Here's another example of how subcapsular hematomas can be difficult to see by ultrasound. This is one where we just saw that reversal of flow, but the kidney graft itself looked reniform, so we didn't raise that as a definitive diagnosis, but sent the patient on to CT, and sure enough, you can see a subcapsular hematoma. Now, the ones to be really concerned about are these medial hematomas, and here you can see in this case here, there's a medial hematoma right here, which correlates with what we see on CT right here. And the reason those medial hematomas are important is sometimes they can indicate that there's a problem with the anastomosis, that there may be an anastomotic breakdown or some kind of infection involving the transplant vessel that has led to rupture. So in this case here, you can actually see this hypodense area on the CT surrounded by a more hyperdense clot. This is actually a pseudoaneurysm that's developed because of a rupture in the transplanted renal artery. Here's another example here of a medial hematoma that when you give contrast, you can see there's multiple pseudoaneurysms within this patient, and this patient ended up losing the kidney graft. So it's important when we see a medial collection that we evaluate the vasculature really well with ultrasound as best as possible. And if we can't see something, maybe suggest that a CT be done. So here you can see there's this collection medial to the graft. Good evaluation with B-flow shows the swirling appearance within this. This is an extrarenal pseudoaneurysm. Finally now, we'll get to the parenchymal issues related to a kidney graft. Now, when a kidney comes out of a patient, you can see the endothelium of the vessel and the lining of the tubules are normally perfused. Now, when you take the kidney out, there's a time when the endothelium of the vessel, as well as the lining of the tubule, becomes without blood flow and can become ischemic. And then it's reperfused, and the cells will swell up because they have some kind of injury associated with them. And this may be it. Maybe it swells and then it goes down. This is acute tubular injury, the swelling of the vessels. But if it stays around too long with the swelling of the cells, you can actually lead to decreased perfusion of both the tubules as well as the endothelium, and can lead to either acute tubular injury or, in this case here, acute cortical necrosis. So how does that look by ultrasound on Doppler? Acute tubular injury, just like we talked about before, is going to be this low perfusion state. You're going to have elevated resistive indices. But importantly, you want to see the renal vein. And if you see a patent renal vein, it's most likely going to be caused by acute tubular injury. These things are self-limited, they're diagnosed on biopsy, and they usually happen in the immediate postoperative setting, or if a patient has witnessed a hypotensive episode. When we're dealing with acute cortical necrosis, the findings can be subtle, actually. You really want to look for cortical perfusion, and absent cortical perfusion should raise the possibility of acute cortical necrosis. Even in the setting of normal resistance, there's a phenomenon called the Trueda phenomenon, where when you have acute cortical necrosis, blood actually gets shunted away from the cortex and down the medulla. So you can oftentimes, in patients with acute cortical necrosis, have completely normal resistive indices. The diagnosis can be made definitively either on biopsy or contrast-enhanced ultrasound if you see absent perfusion on contrast-enhanced ultrasound within the cortex. And then rejection classically has been evaluated by Doppler ultrasound, classically increased resistive indices, increased echogenicity. It seems like those sonographic signs don't really hold up in patients with rejection. And the only thing that really seems to pan out as far as being sensitive for looking for rejection is the presence of urothelial thickening. In this example here, you can see the cortex looks nice and normal. There is profound urothelial thickening that you can see here. But you can see the perfusion is normal, goes out to the cortex, and the resistive index is normal. And this patient ended up having rejection. So looking for urothelial thickening and maybe downplaying the significance of acute, of increased resistive indices may be warranted in patients with rejection. So take-home points. Perfusion out to the cortex, looking at that is important. Venous thrombosis can mimic acute tubular injury, so look for the venous outflow. When looking at transplanted renal artery stenosis, the three major criteria that are important are velocity greater than 300 centimeters per second, spectral broadening, parvus-tardus waveforms. Think about, transplant renal artery stenosis on ultrasound as not being binary, or if it's not there or it is there. There's a large percentage of patients that may be in that indeterminate region, and considering a CTA or MRA may be useful. Doppler vibration artifact is highly sensitive for arterial venous fistulas. When we think about hematomas, subcapsular hematomas can be difficult to visualize. So when we see reversal of flow, we should think about that with high suspicion. And And when we see a medial hematoma, really look at the anastomotic regions as best as possible with ultrasound. If we don't see it well, consider a CTA or MRA. And then finally, Doppler evaluation for rejection is probably limited, and to look for urothelial thickening, which is a sensitive feature. So thank you very much. I appreciate your time.